Hi, good morning, everyone. I would like to welcome all of you who are sitting in this auditorium and the other that join us online. So this is the last session of this morning. The topic entitled Pandemic Turning to Endemic, how the world can learn to live with COVID-19. So this is the interactive session that I will not have not some I have only one slide to show you, and I'm really lucky to have our panelists, Dr. Tanarak and Michael Callahan, who join us from the US, and Dr. Linfa Wang join us from Singapore to participate this discussion. So I would like to say hi to my colleagues overseas. Can you hear us?
Yes, thank you.
Okay, good morning. So as of March 2022, we have seen nearly 5 million cases of confirmed cases of COVID-19 with 6 million of deaths from this disease. So I think that right now we have seen some change in different countries, like in the US or in some country in the European countries, the daily case start to drop. But in Thailand or some Asian countries, the number of new cases is rising or stable. So I think that each country have different response in terms of how to fight with COVID-19. So I would like to know about the situation in your countries and in Thailand. So I'm going to start with Professor Linfa. How is the situation in Singapore now?
Yeah, so in Singapore, that the Omicron basically hit us very hard, BA1 followed by BA2, and but we like to believe that it already passed the peak because the daily cases and hospitalization started to decline, right, by maybe 20-30% from a few weeks ago. So the Prime Minister yesterday at 11 a.m. just announced the further relaxing. For example, right now we can only go to restaurant per table, sit with 5, so that now be increased to 10. The other thing, as you know, Singapore's mask wearing has been 100% stringent, whether indoor, outdoor. And so up until now, we had to wear masks everywhere we go. And from basically 29th next week, that we can, it's optional. You can still wear mask outdoor, but it's not compulsory. But indoor is still compulsory. And then in terms of capacity of the room, we allow 75% of people coming back to work in office and 25% still work from home. So Singapore is a conservative government. So what we're doing is that, between USA, UK, and China, basically, we want to open up, but not fully. Okay.
Yeah, we heard that few days ago, your Prime Minister just announced the policy that they will launch living with COVID-19.
Yeah.
So are there any significant message from your Prime Minister to implement these strategies?
Yeah, I think the key message is that we're going to discuss later. I mean the international community now have to realize that eradication of the virus is not possible in the foreseeable future. So live with the virus, I think I think even China now, they have to realize they have to live with the virus, but the interpretation is different. How do you live with the virus, right? So in Singapore, the message is that we will gradually, incrementally relax, but we will not have a full opening up. Yeah.
Okay, thank you. So what about you, Michael? What is the situation in the US now?
Yeah, so unfortunately in the US, our relaxation of our protocols and our public health controls, we call them non-pharmaceutical interventions, masking, social distancing, remote school and remote work, these were all suspended largely at the same time across all 50 states. And it happened at a time when community transmission of the virus was going down, but there was still too much Omicron BA1, the original Omicron strain, in the community. So what happened is we instantly saw a flattening of the descent, and now we're seeing an uptick. In this morning, it was 17 of our 50 states are showing an uptick in virus. We have some forecasting tools that are brand new over the last year, and these the best ones we have are wastewater monitoring of coronavirus RNA. And by watching it in our wastewater treatment facilities, we are predicting fairly accurately about 3 weeks in advance for community surges. And unhappily, we're seeing coronavirus levels in our wastewater escalate quite in a disquieting way. So the US is entering a period of flattening in the descent of cases, followed by an increase of cases, partly due to the relaxation of precautions and partly due to BA2. In our country, BA2 was only about 10% of our sequenced viruses. Looking at the data 22 days ago, then about 17 days ago, it was 1 out of 4 viruses. Now, in many parts of the US, it's 1 out of 3. 1/3 of our strains are BA2. Why that's important is that we have the relaxation allowing BA1 to take off, and then BA2 is, as Linfa was mentioning, it's a super specialist virus. It's really a perfect pathogen, and it will find all individuals that are not sufficiently immune protected by the vaccines in their boosts, or that might have escaped an Omicron 1 infection from BA1. So we're in for a couple weeks of flattening or no further improvement. And in many areas, you're going to see an increase in cases. And then before we anticipate a return of the downward slope. Barring the evolution of a new virus, we'll call it BA3 because it'll probably be in the Omicron lineage, but it might be one of Linfa's COVID SARS-3s. That's quite possible, but depending on what's happening internationally. We think that we have a little bit of a holiday in the US for our summer, our northern latitude summer, and then we will be dealing with an endemic virus, which can again escalate quite sharply if we have new variants that evade our vaccines or evade waning immunity, make use of our waning immunity, or worst case scenario is yet another VOC or variant of concern. So.
Great, thank you. So let's get back to Thailand. I will ask Dr. Tanarak to give us how do you think about the situation in Thailand right now and what we should do, because we are now approaching Thai's New Year's festival. So what should we prepare? How should we prepare?
Okay, the situation in Thailand at the moment, I will have several points on this. The first one is about, let's say, the spread of the disease. Currently, if you ask how many cases were detected every day and reported to Ministry of Public Health, and how many we report the number out, it's roughly about 50,000 for quite some time now. 50,000 cases per day that has been reported. And the second question, if you ask is there any underreported cases, I would say yes. So the true figures of how many persons infected in the countries each day will be somewhat higher than the numbers that we get. How much higher is depending on what is your belief the figures would be. But the truth is that the Ministry of Public Health and the hospital do not count every cases. And I don't think it is, in some sense, it doesn't matter that much that we have been able to count every single cases. Okay. And if the trend is increasing or decreasing, I would say I believe that the trend is still increasing. There would be more infection in the next few days or weeks to come, especially after Songkran holidays. If we remember the history, today I told a lot of history. Last year, after Songkran, the epidemics, the spread of disease also take up increasing after Songkran. This year, probably with so many people expecting even more travel. So if there is more travel this year, then there would be more cases after Songkran. That's one point. Second point is that at the moment, the most important figure would be number of severe cases and number of deaths, especially number of severe cases. Number of severe cases also increasing. That we have to be very careful that don't let the situation of last year happen this year. That is the situation where the healthcare system has been overwhelmed by the number of cases of COVID-19. But hopefully, because of the severities of these variants that we are facing this year, I think that we are going to be okay. So increasing, but I think we are going to be okay if number of cases are not increasing unexpectedly much more than what we have today. The third point is that to prevent the death or to prevent severe diseases, one of the most important strategy or the most important thing is to vaccinate people. And I think the most important groups of people that should be vaccinated is elderly and people with chronic conditions. If you look at the figures, we are vaccinated now closely to about 80% of the total population. But if we look at the figures more closely, I don't think we have done a good job on vaccinated the extreme age population yet. We have done very good job on vaccinate people 60 to 70 years old. But 70 to 80 years old the coverage will be less than 60 to 70s. And the vaccine coverage will get lower as the age getting higher. And for anybody who age more than 90 years old, vaccine coverage is about 30%. On the opposite, I mean, if you look at the other countries that have done quite a very good job on vaccination, especially high-risk population. You will see that, for example, the UK, the older the populations, the higher the coverage is. So I think there are still rooms for us to do to improve the situation before Songkran is coming. So what is important for Songkran? Two things. We should be vaccinated, the elderly, as much as we can, especially for anybody who did not get any vaccination yet. If you look at the figures of people who die each day, then there will be elderly without vaccine or without appropriate vaccination. So still, there is still rooms to do. And vaccination should be, given to the elderly as soon as possible, because it takes time before the antibodies kick in. And the second thing is we have to enjoy Songkran carefully for ourselves and for the one we love, especially the one that is is old. Our father, our grandfather. So we have to be careful about that. We can visit them, but with awareness of what is going on. Today, there are more cases than ever. In the last 2 years, if you ask me when is the times that we have more cases of more prevalent cases in the country, I would say now. Currently, there are more active cases than any other times in the last 2 years. So In preparing for Songkran or what will happen after this, I think we have to be keep ourselves aware and do whatever we can to prevent that.
Thank you. So people are talking about turning the pandemic to endemic. So I would like to ask for your opinions, how the endemic look like from your perspective. I'm going to start with Michael first. How do you think about the endemic? What is the picture of endemic disease of COVID-19?
Michael, can you hear?
Can you hear me?
I cannot. I'm sorry. What was the question?
Okay, so I would like to ask how the endemic look like from your perspective.
The question is that we are going from a pandemic to epidemic, and what's your personal view of what an epidemic will look like from now on?
Okay, thank you,
Very
Linfa.
good. So thank you, Linfa. I appreciate that. I apologize for the audio at my end. So the modeling in the U.S. and our belief looking at North America, including our partners in Canada and Mexico, is that all three nations are going to be moving out of the most impactful parts of the pandemic, leading us to an endemic that's characterized by seasonal swings of the virus involving the very efficient and highly infectious Omicron, and its return will be dictated by two large things. The big one is waning immunity. As Linfa mentioned, long-term immunity is a daunting challenge with coronaviruses in general, and we are seeing in our case, we're tracking a number of patients that have already been infected twice by Omicron, and it's only been around for about 3 months. So this tells us that as the American population immunity drops, we're going to have surges of the current strain. Now, the worst case scenario for us is, of course, a new variant comes out that defeats the vaccines. Regarding the question of what epidemic outbreaks will look like, we think that when the U.S. moves into its colder season and we have aggregation and people moving indoors, and we don't take precautions, and we return to 100% occupancy of our retails, our restaurants, and our places of work, that we're going to see significant escalation in the cases. My last point is that there are Omicron-specific vaccines under development. In the West, we have 3 manufacturers which are probably going to put forth packages, meaning to the regulatory, to approve Omicron vaccines, and those are likely to be much more useful. But again, we would need to get those vaccines international as quickly as possible. So CEPI and other organizations will be helping with that, as well as facilitating the development of other vaccines, such as the ones that Linfa has described, and other nations making Omicron vaccines. So we have a lot of solutions ahead of us now.
Thank you. Well, what about you, Professor Linfa? Do you have anything to add?
Yeah, I think, I largely agree with what Michael is saying. I think I always say that when I get a question, say, what do you think will be the next year, 2, 3? Then I say the big uncertainty is variants, right? If BA2 is the last one, then as Michael says, we actually have quite a few ideas and a weaponry in our sort of, reserve, although not ready, but we're developing, right? And then so, I mean, Michael, it's really interesting, your idea, coming from the flu experiment, you live attenuated, you vaccinated 6 chickens, and to say, the vaccinated one gave you only 1 variant, and the non-vaccinated one, gave you 5, 6 different ones. So I hope your kind of theory is playing out, because our data clearly shows Omicron would not have evolved that rapidly as a variant if we have a naive population. Omicron evolved is under the immune selection pressure, either you get it from infection or vaccination, which could be a good thing if Michael's theory is realized. So we forced Omicron to emerge in less than 2 years since the 2019 December. And that will be a virus is so fit, no other virus can beat it in the next foreseeable future. Then we can work on a vaccine that can protect the Omicron BA2 better, and hopefully with the international, effort, is also working into the two other. So I always say the vaccine has three kind of shortcomings right now. One is the breadth, right? Because our vaccine don't protect Omicron very well, so we are catching up. We try to increase the breadth, like my data suggests, it's a pan-sub-equal. Secondly is longevity. That's the hard one. We still don't know how we can prolong the immune longevity. And the third one is the site of protection, the location, so mucosal immunity. So there's a lot of effort. Also try to say maybe the next booster vaccine, if we can combine all three, better to protect Omicron, last longer, and also have more mucosal immunity, then I think it's just a matter of the vaccine equality. If we can produce that fast enough, cheap enough, and for the whole world to get a booster, then the future is very bright. But I think that's like the best scenario. So I think the chance of getting there is not very high. So the most likely realistic is what Michael has kind of outlined, is that we will go season by season, year by year, adjust, and hopefully we have lots of vaccines to choose from, and then different governments make different decisions. And then largely, we will not have to shut down again. But winter, we have to be more careful. And the elderly, there's still people will die. So that's where be the scenario. Thank you.
Thank you. So what about you, Dr. Tanarak? How endemic disease look like from your perspective?
Just to add what has already been said, I think this is probably the situation for Thailand, where the resources are not as rich as Singapore or the US. I think one of the most important thing is probably the capacity of the healthcare system to be able to handle the COVID cases. We have to understand that even as I mentioned earlier in my talk this morning, that even before COVID-19 arrived, our resources that we have for Thai citizens is not as that good. And when we need to spare some of the resources, the hospital beds, the doctors, or whatever, to care for COVID patients, we have to be very careful that other patients, cancer patients, heart patients, and other kind of patients will not get a good care during this time. So to me, during the endemics, when we are saying that each country will have different timing on saying this is okay for our countries. It may not be the same everywhere. As we can see, some of the countries still use very strict measures to try to control the number of cases. We may have to be vigilant and very careful on the situation in terms of caring for the situation and caring for patients. And it doesn't mean that, as I showed in the slide earlier as well, that when we say it's endemic, it doesn't mean that the threat or the danger has gone. It's still there. Even if it is not, even if we do not have the new variant, even for the old variant that we are facing. And then there is a threat that we may have the new strain of virus again. So there are several things that we still have to do. But the most important thing is hospital management in terms of caring for patients and prevent hospital infection, preventing the hospital staff and preventing other patients from getting COVID from the active COVID patients.
Thank you. So it seems that all the panelists agree that many countries are preparing the transition from pandemic to endemic, but they prepare differently. The thing that you mentioned is about the vaccination, and it should be focused mainly in vulnerable populations, for example, the elderly people and people with chronic disease that may progress to to severe COVID-19. So in terms of the vaccinations, Michael, you talking about the mass production of the COVID-19 vaccine by using tobacco. Is there any challenge on that technique? And is it possible to make it like a mass vaccination?
Great question. So I ultimately do not care which vaccine manufacturing system that you use. It's a question of which expression system is suitable for regional delivery. So places where every large country greater than 30 million people have their own vaccine capability for 30 million. The reasons for this is that it allows each country to be independent. I mentioned tobacco because it was neglected by the early investments in coronavirus vaccines in the US, and we have misgivings about that because its practicality and its ability to be replicated globally in indoor greenhouses is remarkably low cost. They've also produced, rather stunningly, they've produced monoclonals at full GMP at extraordinarily reduced costs. So as a tropical infectious disease doctor, my concerns are always the tropics, and the world's poor. So getting these capabilities that are low cost outside of Western nations is very important. Besides tobacco, probably the other protein subunit vaccines, such as those that have been produced by the same technologies that are used for hepatitis B surface antigen, and several of the other technologies that have been advanced by CEPI are all suitable. All we care about is safety, efficacy, obviously, reasonable efficacy, and ubiquitous availability, rapid availability to these countries early so that they can control their own epidemics in their borders.
Thank you. So another question from me. It seems that when we talk about the endemic virus, when we look at the characteristic of the disease by the virus that we have known to be endemic disease, for example, human coronavirus, reproduction number is really low, less than 1. But right now we are now having Omicron, which reproductive number is 6. How could it be in the future if we want to make the transition from pandemic to endemic? What could be done to suppress the reproductive number from more than 6 or 6 right now to less than 1? I will start with Professor Linfa first.
Yeah, so that's a very good question, right? It's unknown, but the reproduction number, we always say, the absolutely kind of natural number, we cannot really get anymore because we are not talking about naive population. Internationally, very soon, most people will be vaccinated. So the virus will continue to mutate, and we will see which direction it will go. But we are hopeful that as Marco says, if we have better vaccines to prevent the shedding and the transmission, and that will reduce the R naught down by a significant number as well. So that, I think we're still hopeful that eventually we'll have a vaccine to deal with the current BA2. But if it evolves in a different direction, then that's a different matter. I agree with you, with the current infection rate, I can see the only way to go to epidemic means that you don't hear, like in Singapore, a population of 5.6 million, you have 10,000 infections per day. That's just still too much, right? But that will not last if it's only BA2, because we now have 20% of the population already infected and 95% vaccinated. So that if this thing goes as the current rate, then I think it can only go for another 3 to 6 months, and then it will come down. The R naught will come down. Yeah.
Much. So, Dr. Tanarak, do you have any comment on this? How to suppress the? Okay.
Yeah, Linfa's great point was that the R naught is determined against the denominator, which changes as individuals become vaccinated and as they convalesce from prior exposures. The R naught is driven down, so the virus, in order to be successful, if it was to maintain that high number of 4, 5, or 6, must be a changed virus. It must adapt to evade that immune protection to maintain those high numbers, particularly in a nation as well vaccinated as Singapore. So this is an important point, is seeing a high R naught in the current well-vaccinated populations is a worrisome sign. It could indicate a changed virus. And our second point is where you go to look is important. Do we continue to surveil with the same energy the unvaccinated populations, or where is the new problem virus going to come from? It's probably going to come from populations that are immunosuppressed and vaccinated, or vaccinated with waning immunity. For us in the US, the viruses that come out of people with waning immunity are much more worrisome than the viruses that we see in the unvaccinated. So we should probably focus our surveillance to generate the highest data to protect us.
Thank you.
Actually, I don't have much anything to add to Dr. Wang and Michael. But I think the very important point will always be if we have protective immunity or not. There are not just when we are talking about the infectious diseases, not just COVID-19. We can talk about measles and other infectious diseases that we have been able to tackle the problem. With measles, where the disease spread even more rapidly than COVID probably. The protective immunity will always be able to suppress the spread of disease down and have less number of reproductive numbers. So I think as I heard the speakers said in the early morning session, that in the end we are very hopeful that we are going to have second, third generation of vaccine that's probably even more effective than what we have today, and can catch up better with the mutation of the virus. I think that would be probably the most important things and probably most important development that we are looking forward to.
Thank you. So technically, how people, when we talk about the vaccine, people think about the vaccine can prevent infections and prevent severe disease. But right now we are having the problem with vaccine that we are using right now cannot prevent infection very well as we had expected. So in the technique, how to improve the quality of vaccine that can prevent infection instead of prevent only severe disease. Can you have any comment on that, Michael?
Yes, it really must be directed against targets that are associated with the primary infection. To prevent the initial infection really is a very high barrier. We were very impressed with the fact that while, as you noted, the vaccines prevent severe disease, but oftentimes there's subclinical infection. When we swab our vaccinated individuals and we get virus from them, they are not ill and they're well vaccinated with very high neutralizing antibody titers. So to your point, preventing primary infection that's really the ultimate goal, because then you're going to prevent any sort of encoding of immunity that might not be useful, or prevent even mild disease and lost work days, and importantly, transmission. This usually requires multiple targets. You can't just do an S1 receptor binding domain, Th1 and Th2 immune response. You need something more elaborate. And that's where I would turn towards Linfa and others for comment. But typically, you need a very complicated vaccine that's very potent and does not senesce. That means it does not wane over time and allow these viruses to get on board. Linfa, would you have any comments on a absolute vaccine to prevent primary infection at all levels? Over.
Thanks, Michael. The challenge, like my personal story I share with a paramyxovirus vaccine versus a coronavirus vaccine. So unfortunately, the nature is against us that it released emerging coronavirus, because if you look at the history, right, even natural infection, measles virus infection is famously, we learned that sometimes can give you a protect lifelong immunity. Okay, so it's a paramyxovirus. Now you switch to coronaviruses. From virologist point of view, until SARS emerged, I always say, virologists don't think coronavirus is sexy. Sexy in virology means that kills, right? So coronavirus has not been thinking as a dangerous enough, so we don't have put enough effort in the human side. But in the veterinary side, actually coronavirus has been killing pigs, chickens actually, so we know it can be lethal. But to this date, we don't have an effective vaccine for pigs against different coronaviruses. Okay, now there are two sorts of schools of thoughts. One is to say we have not tried hard enough. The other is just to say coronaviruses are hard to get a vaccine that prevent infection. Okay, I think as a scientist working in this field, it's still too early to make that kind of death sentence. But from my personal perspective, it's already showing that it's going to be much more difficult because our lessons from the vaccines of the SARS-CoV-2 is to say, compare with the two families that I have experienced, paramyxo versus coronal, the coronavirus immunity is so virus and strain specific. As I've demonstrated, right, the receptor binding domain, as Michael says, that alone will not protect us. But even in that domain, all you need is 2 amino change to get a beta, and then your current vaccine have a discount reduction by 20, 30, 40%. That will not happen with the paramyxovirus. So I think the future, I cannot say that we will never get there to get a vaccine that lasts forever and can protect different variants. But I think the challenge certainly is that I think the mucosal immunity now is getting more and more attention. So maybe to prevent the infection, the shedding, we have to really to target the mucosal cavity so to get enough immunity there so people will not be able to get infected. And then if you don't get infected, then you obviously will not be able to shed, So sorry, I don't have a crystal ball, but I think that we have to really look into the immune response of the family of the virus. So it's really good to the basic before we can come up with a better vaccine strategy. Thank you.
Thank you. So we have 5 minutes left, and I think that I can take some questions from the audience. I have seen some questions from the chat, and there's one question about the prevention of the next outbreak. So how should we prepare for the next outbreak? I'm going to start with Dr. Tanarak first in Thailand.
I think to prevent the next outbreak would be very difficult, but I think we can always be prepared. And as I discussed earlier, I think we know quite a lot about what we should do. Quite a lot about what we should do. The most important things to me is probably we really have to do it, and not just. The Ministry of Public Health, I think, is everybody's. Not just, let's say, if we want our countries or Thailand to prepare for this. As the question that I mentioned earlier, if there is 27 typical pneumonias happen to occur in Bangkok, can we really detect that? Let's say if 13 cases come to Chulalongkorn universities and another 5 go to Ramathibodi Hospital, can we really detect these 27 abnormal cases? I think those kind of things is the areas where we have to be improved, areas that we have to work together. And there are several other things that that all the parties that's really involved in improving all of this have to join together, because in the end, at the end of the day, it wouldn't be just one. I mean, one single parties or one single agencies that will be able to do this. When we first detect COVID-19 in our countries, it is an effort that's span for so many agencies that works together. We can set up the system to screen at the airport with the help of so many agencies, not just Ministry of Public Health, but also Airport Authority of Thailand, the police department, Bamran Naradun Hospital, of course, Department of Disease Control, but also other agencies at the Ministry of Public Health as well. And also the laboratories here in Chulalongkorn universities and other laboratories that work together from day zero, not day one. So it is not, we don't know what to do. But I think we have got to commit to really want to do it so badly, then things will happen.
Thank you. So, Professor Linfa, do you have any comment on this about the human and animal interface to prevent next pandemic?
Yeah, so I think, we were all involved with the US big predictor project, so I think it's a $250 million in the last, 10, 20 years. So I think the human-animal interface, as I said, is the ideal place to prevent the next pandemic, but unfortunately, the return for investment so far is low because I think there's so much out there. Even like I always say, if we detect that sequence of SARS-CoV-2 in bats, even if it's 99% identical, would we raise the alarm bell? No, because we were forced on something SARS-1 related in those days, right? And MERS related, So I say, the H1N1 in 2009 is a very good example, when the international community has such a intensive surveillance for flu and yet could not predict and prevent the H1N1, then to prevent a novel, known unknown virus, I think it will be much more difficult. But coming back to what I was describing as SARS-CoV-3, if my prediction is right, if SARS-CoV-3 is another Sabeco virus, then what we're doing internationally may be the first time in mankind we can do something proactively to prevent the next pandemic. The reason is that to get out of the current pandemic, we already know that we have to improve the vaccine. We have to broaden the spectrum of immunity, and we have to induce long-lasting immunity. And if we succeed this, maybe accidentally, we also achieve the next goal is to prevent SARS-3 and SARS-4 because that so many coronaviruses in that subgenus we know is circulating. Even in Thailand, right, we discovered many viruses that is ready to jump because the virus can use ACE2, But having said that, when you successfully prevent a potential outbreak, nobody knows, right? So how do you prove that, So that, that's kind of, it's a circular argument, we pass that to Michael maybe.
Thank you. So we are running out of time. So I would like to say thank you all panelists and thank you for the audience